has made 302 tests without even knowing anything, without even taking any opinion, without even knowing what are the laws, without even knowing what is the what is the direction of the body. Never ever they take 302 can be put on the medical profession by treating it. Now, this is what actually this entire thing is. I'm sure this is a very vast topic, very nicely covered by Sharad. Thank you very much for this entire thing. And while we will have interactive sessions, we will be able to answer some of the questions. Some questions will still remain unanswered. Some of the questions will remain to be answered. Some of the actions to be taken by me or by medical association, by public and by medical colleges, or by everywhere, wherever they are. So I'm sure this entire thing, I just want to inform you that Indian Medical Association is going in Supreme for against that police officers who have framed that 302 case and getting directions from the Supreme as far as Jacob Matthews is concerned. We are asking for some more prayers into that thing, which should be filed in another 5 to 6 days time. It is under preparation and all those things. So this is what. Thank you very much once again, and I'll like to restrict questions. You want to say something, please?
Actually, this is a coincidence when the suicide was committed by Archana ji. What I would like to say at this point in time is that it was a coincidence that during that period only, a day before, we finished a training on maternal death surveillance response. And I was leading the Jodhpur team in Jodhpur, and they have conducted maternal deaths in whole of Jodhpur. And it is MDSR. That means maternal death has got to undergo surveillance wherever it takes place, whether in the home setting, during transit, during hospital. Now, you see, what we are worried is also about the hospital setting. But how many, of our physicians, gynecologists, are aware that there is something as surveillance and response, which calls for need of regular upgradation of doctors, that is one thing. But I will also say awareness of the laws, which Dr. Vinay, you already pointed out so vividly that, we have to be aware of different sections, why they are there, kind of, and regularly updating ourselves. And you mentioned one very important point is communication skills. But Dr. Agarwal is with me, I'm just looking at 20,000 footfalls in OPD of Malana Azad Medical College. वो बेचारा एक डॉक्टर क्या करेगा उस टाइम I remember in I'll say 1979 doing interning at सेवाग्राम डिस्ट्रिक्ट हॉस्पिटल वर्धा. इससे पहले कि आप पर्चे लिखते हो दूसरा मरीज आपके सामने होता है करके. So somewhere I think we need to look at appropriate doctor population ratio, or we have a concept of nurse practitioner, which is so very important. So this is because the time is short, so I'll raise these are some of my important.
Dr. Vijay to give a concluding. Yeah, sir. After Vijay.
I think first of all, I'd like to congratulate Sharad for very comprehensively covering this topic. But what I would like to highlight to you is something probably what we are missing, and where probably we may need help of somebody like Nimish Desai in the society. And that is, I'll tell you, the intolerance to an unfavorable outcome. You see, the issue is this: right from childhood today, what is happening today, you might see that your own children are becoming very intolerant to something that is not going their way. And therefore, this problem that we are seeing in the medical profession, it is there all around in the society, whether it is a road rage and a person is being, or it in a public brawl, anywhere. People are dying, and yes, we are also getting our fair share, and you are very comprehensively treating that. But I think that somewhere along the line, we should try to raise a voice for undertaking certain things right in our medical, in our schools, in our as children. Let us try to make them understand, or let us try to make them understand the importance of losing, importance of something has not gone your way. Then those kind of tantrums. And I think that's where we'll request somebody like him. I'm saying parallelly, it doesn't kind of take away all the actions that you have taken are extremely important. But I am saying, I am trying to raise something. Public is not accepting a unfavorable outcome. So there have to be civil ways to address those grievances. That's number one. You have already had Consumer Protection Act. You can have many more. There should be civil ways to do that. But I think even more than that, let's try to inculcate in our children the capacity to lose. I think that's very important.
Thank you. Dr. Arun Agrawal. The last comment, sir. Expert comment.
Dr. Vinay, Dr. Monga, Sharad. Sorry, I came late, so I missed the best part of it. But only thing what I could gather, मैं अपना कुछ एक प्रीवियस एक्सपीरियंस बताना चाहूँगा जिसको मैं कुछ कंपेयर कर रहा हूँ, लेकिन ये टोटल कंपैरिजन नहीं है। आपको याद होगा 2007 में गवर्नमेंट ऑफ इंडिया में एक ये मुद्दे या तो पार्लियामेंट में उठते हैं या सुप्रीम कोर्ट में उठते हैं, तो रैगिंग का मुद्दा उठा था। रैगिंग का मुद्दा उठा और उस मुद्दे को फिर अल्टीमेटली सुप्रीम कोर्ट ने, मुद्दा यही था कि हर साल रैगिंग के दौरान कुछ बच्चे की डेथ हो जाती है, कुछ बच्चे छोड़ देते हैं, कुछ बच्चे हैंडीकैप हो जाते हैं, कुछ लोग डॉक्टर देसाई के कंसल्टेशन में चले जाते हैं। ये बात फैक्ट है। मैं पूरी इंडिया की बात कर रहा हूँ, डॉक्टर देसाई से मतलब पूरे इनके कोलीग्स। तो उस मुद्दे को लेकर जब सुप्रीम कोर्ट ने एक कमेटी बनाई जिसको फिर राघवन कमेटी का नाम दिया गया, और फॉर्चुनेटली आई वाज मेंबर ऑफ दैट कमेटी। उसके मेरे साथ मेरे कुछ वाइस चांसलर थे। वो मुद्दा हम लोगों ने पूरे इंडिया को देखा, समझा, कुछ वाइस चांसलर से इंटरेक्शन हुआ, टू डाउन अप टू स्टूडेंट्स डिफरेंट स्टेट्स में। और उसके बाद जो रिकमेंडेशन आई, उस रिकमेंडेशन में द आंसर वाज से नो टू रैगिंग, जीरो टॉलरेंस। उस समय बहुत लोगों ने कहा नहीं डॉक्टर साहब, थोड़ा सा रैगिंग तो होनी चाहिए, हैं? डॉक्टर छाबड़ा के कुलीग को कहेंगे अरे यार थोड़ा इंटरेक्शन से थोड़ी आपस में एक्शन बढ़ता है, दोस्ती बढ़ती है। लेकिन समहाउ कमेटी ने पूरी कंट्री के एटीट्यूड को देखते हुए कहा नहीं, हम जीरो टॉलरेंस, ठीक। और उस जीरो टॉलरेंस का असर ये हुआ कि आज के दिन मैं ये तो नहीं कहूंगा कि रैगिंग खत्म नहीं हुई, लेकिन मिनिमल हो गई है। इट हैज बिकम मिनिमल। हमारे सामने एक केस स्टडी है, हमारे सामने केस स्टडी है। उसको मैं रिक्वेस्ट करूंगा कि उस केस स्टडी को हम अपने, हमारे पास जो मुद्दा हम बात कर रहे हैं और पहले भी बात करते रहे, उसको देखने के लिए एक केस स्टडी है जिसकी एक सक्सेस स्टोरी हमारे सामने है। कैन वी थिंक दैट?
Thank you, sir. I think very rightly said by Dr. Arun Agrawal, and that zero tolerance to violence. मैं इसको इस सेशन को समाप्त करूंगा सिर्फ आपसे एक प्रार्थना से कि start appreciating, stop criticizing your professional colleagues. Start appreciating, stop criticizing. I go to another step, that stop criticizing your own professional colleague even in front of your spouse. This process has to start, and this is slogan of appreciating and criticizing. I'm being in Delhi Medical Council with Dr. Arun Agrawal for 10 years and with Medical Council of India Ethics Committee for 5 years. I can only say 90% cases, if cases of complaints and negligence are being erupted by our own professional colleagues against our own professional colleagues, then you can even say that violence is also somehow or the other has some origin of some of the relations, medical relations or others, or persons related to medical profession of the so-called patient or the victim or so-called accused or so-called perpetrator, whatsoever you can say. तो हमको एक बार से अगर ये सेंटेंस लाना है जीरो टॉलरेंस टू वायलेंस, तो हमको ये भी सीखना पड़ेगा कि स्टॉप क्रिटिसाइजिंग, स्टार्ट अप्रिशिएटिंग. Thank you very much. Thank you, Sharad.
Thank
and
you.
Dr. Monga, for
Thank you,
giving
Dr.
us-
Vinay.
Thank you.
Very good illustrations by Dr. Sharad, and Dr. Vinay Agrawal, as usual, was at his best. With input from Dr. Sunila, Dr. Arun Agrawal, and Dr. Vijay Agrawal. Thank you, sir. Thank you very much. I think they need a big clap for putting up their issues. Thank you, Sharad and Dr. Vinay. Friends, this double helical conclave is being arranged by the support from KAHO and AHPI. These two organizations are definitely nationwide, and they are talking about various health issues, affordability, accessibility, then talk about quality, then talk about infection control, then we talk about various issues of healthcare professionals also. And I'm going to, call upon first Dr. Girdhar Gyani, the Secretary General of AHPI. He has his headquarters in Delhi and massive presence all over the country. Initially, I think they started with moderate to bigger hospitals, but now they are making members of even small, number of beds also. And he is a full-time personality, administrator. And if you go to his office, he's always on the job, listening to the problems of doctors. Whether we talked about the salary of nurses in Delhi, Delhi government order, or we talked about the oxygen issues in COVID times, or implementation of various government schemes. I think Dr. Girdhar Gyani is really a leader in that, sir. And similarly, I'm going to request Dr. Vijay Agrawal. तो विजय अग्रवाल तो सर हम सबके टीचर हैं. I think he is the senior most person here. When I entered medical college, he was already into practice. Started in Roopnagar in a hospital, then became an administrator. And sir, salute. And not only that, I mean, KAHO is an organization which has many members, and especially in South and North India, they hold so good conferences that people pay in thousands to come and attend those meetings or these workshops just because of their contents. So, I mean, we are definitely lucky to have this Jodi here. And sir, I'll request Dr. Girdhar Gyani to talk about accessible and affordable healthcare. I think this is a very pertinent issue all over the world. Globally, people are talking about it. Whether it is a forum of physicians or a forum of general practitioners all over the world. And I must congratulate our central government that 3.5 years back, they brought in this scheme, Ayushman Bharat. That was, I think, still a step in the right direction. That it should be accessible, it should be affordable. And Dr. Gyani has done a lot of work on this. So I'll request him to please come up and present his expertise here with us. Thank you, sir.
Yes, so thank you, Dr. Monga, and it's indeed at least my proud privilege to be a part of this particular talk, which is being delivered by none other than Dr. Girdhar Gyani, whom we call as the father of quality in this country. And the topic is affordable and accessible healthcare, sir. And I think this word, affordable and accessible healthcare, is probably a mirage all over the world, not only in this country. I think every country is kind of struggling somehow. And when it comes to the word affordable, my mind really starts to think, are we talking about affordable from whose point of view? Are we talking, if we are talking about affordable from the point of view of this country, and if you think that by spending 1.2% of the GDP, and we can make it more affordable so that we can go to 0.6%, I mean, I don't think that's what is going to ever happen. So affordable is something that we are probably thinking more in terms, of course, from the individual's point of view. Yes, that's going to be a very, very important point. And accessible is, I think, a even more relevant problem. Accessible is a huge, huge issue. In India, if we look at, because sometimes when we are sitting in the city of Delhi, we probably don't realize the healthcare problems, whatever are there in the whole country. So you have to understand that more than half of the Indian females are suffering from anemia, or you find that 35% children of our country are stunted, especially when below 5 years of age. Our MMR mortality is nowhere near those of the developed countries. And we rank 145th in WHO ranking of quality out of 195 nations, and behind even countries like Bangladesh and Sri Lanka. So these statistics somehow very definitely say we have probably both in affordability as well as accessibility, because if this is not occur. Now I would say that definitely there are a huge amount of government steps which have this problem, and uh, I said absolutely. I look at this somewhere along the line. Yes, the promise of including 50 crore people in this country, but there is somebody is not walking the talk. What is that? There is 11 below the poverty line, enrolled in the scheme, who are standing in front of you, homeless, or they are sitting on the street. And that's where I'm saying this have to be there. I think we will move from Dr. Gandhar.
Thank you, Dr. Vijay Agrawal, Dr. Munga. Today my throat is a little bad, but hopefully I'll be able to manage. Otherwise, my senior colleague is sitting here, he will take care. Now, I wish to, bring to your knowledge that statistics what Dr. Vijay was telling you, you can find ranking, WHO ranking was one time 12 out of 1, then it became 145 out of 195, and 101, 167 also has different survey projecting different statistics, because the criteria are different. But WHO criteria actually based on coverage. But which country is having the best effectiveness on the universal health coverage? Universal health coverage actually can be gauged by 4 things. One is the availability of the obviously doctors, beds, hospital. Second is accessibility. Third is affordability. Third is acceptability. That is quality, what we call quality and patient safety, acceptability. 4 A's. Now, in fact, the last is most important because I have grown out of that profession, but I will not talk about that here, because in my opinion, if you have no availability, no accessibility, quality takes the back seat. You cannot talk about the quality. So anyway, so my thought, I want to show you, discuss a little bit detail on availability and accessibility. Now, these are the 4 A's of universal health coverage. Why our ranking went down? In fact, 1.5 when this survey was done, it was about 3. Allowed to increase the number of beds by 30%. You see, here again, because Vijay is chairing the session, I had the opportunity to visit some of the nursing homes in Thane. Not one, in fact 5, 6. And they were actually supposed to be having 35 beds, somebody 48 beds. And they were known to me because they had undergone training through me. I said, क्या कैसे हो सकता है? आपको दिखाते हैं अल्टीमेटली वन ऑफ देम टू द रूफटॉप, वहां पे उन्होंने शामिल लगा के और बेड क्रिएट कर दिए थे। population was them. I'm talking of the wave two. But in my own mind, I was shuddering to think that what kind of care these patients will get. तो कहते हैं हेल्थ केयर वर्कफोर्स भी भाग गए थे उस समय, तो प्रोटोकॉल का कोई पता ही नहीं था. आई वाज होपफुली बिकॉज कुछ था ही नहीं हमारे पास. तो पॉइंट इज दिस accessibility, availability also comes at the cost if you are not able to take the quality or patient safety. But anyway, I think that was the wartime situation. War में सब कुछ चलता है. We were able to provide. मुझे याद है कि डॉक्टर चावड़ा यहाँ बैठे हैं क्योंकि मैं वहीं रहता हूँ थोड़ा पास में. तो उस समय मेरे पास कम से कम 15-20 फोन दिलवा दी. अच्छे से लोग मेरे को नहीं, ये डॉक्टर ऐसे भेज दीजिए. मुझे पता है कि इनके पास बेड नहीं है, लेकिन ही विल नॉट से नो. तो बाद में पता चला इमरजेंसी के बाहर अभी 4-5 लोग वेट कर रहे हैं. एटलीस्ट बट पेशेंट को तसल्ली हो गई थी कि मेरे को एडमिशन मिल गई. बट एनीवे, आई थिंक दिस वाज वेरी डिफिकल्ट. यू होप इट विल नॉट कम अगेन. सो दिस डॉक्टर शायद हैज शोन नाउ. एक मिनट, इसको मैं पहले ही आपको दिखा देता हूँ. चलिए पहले ये देख लेते हैं हम लोग. This is the 10 major challenges I have listed, which are, we are facing. हो सकता 12-15 भी हो जाएंगे, लेकिन मैंने सोचा ये 10 तो challenges इस समय बड़े relevant हैं. तो 2 are the one which we are going to discuss today. Shortage of the like 1.5. But we in HPI, we have the directory of hospital which is now, and I was myself shocked to see that time that in Telangana, the 100-bed hospital, because tertiary care we consider this was 100-bed home, were 125 in whole Telangana. And बाद में डायरेक्टरी में पढ़ने पलटेंगे आप तो हैदराबाद शुरू होगा पहले, 1, 2, 3, 4 चलते चलते 118 तक पहुंच गया. मतलब 125 में से 118 सिर्फ हैदराबाद में, तो बाकी डिस्ट्रिक्ट में क्या था आपको. आई थिंक दिस इज द स्टोरी ऑफ इंडिया. We have what planning has gone, I do not want to say, but similar statistics I can show you about Tamil Nadu. For example, तमिलनाडु में अगर 200 हॉस्पिटल हैं जिस समय 100 बेड है, अब शायद बढ़ गए होंगे अभी, तो उसमें एग्जैक्टली 100 2 जगह हैं, चेन्नई एंड कोयम्बटूर. हमारे प्रेसिडेंट बैठे हुए हैं एचपीआई के, डॉक्टर मेहता हॉस्पिटल के. तो दिस इज द स्टोरी ऑफ स्टेट आफ्टर स्टेट. So that is where the shortage of hospital bed is fine. The non-availability of tertiary care in tier 3 down. Affordability issue, this also we'll discuss. देखिए even WHO says affordability definition क्या है. You see, masses, even politicians, they believe and they tell that affordability that should be free. मीनिंग अफोर्डेबल है. वर्ड अफोर्डेबल की मीनिंग को डिफिकल्ट नहीं समझना. अफोर्डेबल मींस व्हिच यू कैन अफोर्ड. तो ये कहा जाता है कि नहीं, अगर हम फ्री हेल्थ केयर प्रोवाइड कर रहे हैं, दैट मींस वी आर मीटिंग अवर पॉलिटिकल एम्बिशंस. हमने कितनी बार समझाया गवर्नमेंट को कि पब्लिक इज नॉट एक्सपेक्टिंग. आप 40% ऑफ द पॉवर्टी लाइन है उनको फ्री दीजिए, बट अबव पॉवर्टी लाइन एंड द सुपर रिच पीपल यू give them the accessible health care, but charge them sub component कुछ और co-payment जिसको हम कहते हैं. But नहीं, I don't name all the senior ministers and आपके नहीं वो ठीक नहीं होगा. हम पॉलिसी ये नहीं बना सकते कि हम co-payment चार्ज करेंगे फ्रॉम CGHS पेशेंट और फ्रॉम आयुष्मान भारत पेशेंट. तो ये जो डिलेमा है, मनी हमारे पास है नहीं, we don't have the resources, इतने फंड्स है नहीं. जो आप कह रहे हैं कि आपके ड्राइवर और आपके नहीं है, क्योंकि वी कैन नॉट कवर ऑल ऑफ देम, टू बी वेरी प्रिसाइज। कमिटमेंट तुमने कर दिया है, वो ठीक है, देयर आर मेनी प्रॉब्लम्स कि वो लिस्ट में क्यों नहीं आए, बट अदरवाइज आल्सो टेल यू, आई टेल यू, इन 2018 व्हेन दिस स्कीम वाज बीइंग रोल्ड आउट, सीमेंस ने एक फ्रेंच बड़ा कॉन्फ्रेंस 123 लोग, सॉरी 20 लोग आए थे, एंड दे टोल्ड देयर सीमेंस इंडिया ब्रांच कि हमें यहाँ से कोई ऐसा आदमी भेजो ये समझा सके कि इंडिया इज अ कंट्री with poor resources, how he is able to provide 500 million people free health care. तो गलती से किसी ने वो मेरा नाम दे दिया, मैं चला गया वहां पे बताने उनको, you know, I had to now justify and explain to them that how India can do it. Somehow I think I could manage it and I got some applause there also कि भाई हाँ इंडिया ने ये काम किया है। तो क्वेश्चन यही आएगा बार बार आपके सामने कि why are we afraid? Affordable means provide healthcare to the population at the cost